think we'll make a start. There's quite a few of you on there now. It's a slightly different software to the webinar software we've used previously. So if you do ask questions, I won't be able to see that as we're going along. So I can only have a look at those questions on the chat at the very end. So any questions we can go through at the end. First of all, while I still have got the chat box up, can everyone hear me? Are we good to start? Thank you, Jose. Thank you, brilliant. Okay, now I've got to get rid of this, oh my word. Right. Okay. So I think it was about this time last year that I did a webinar, and I had to apologise for my coughing all the way through it because I had a cold, and I'm afraid the same is again this year. So I might be sipping water periodically through it. Right, so today what we're going to look at, and the subject we're going to talk around, is metatarsalgia. And again, as with previous webinars that I've done, this isn't going to be a hard and fast set of slides and rules about how to specifically treat MET pain, but rather a collection of slides to help you think about some of the biomechanical causes and possible treatments that you could do for patients who come in with metatarsal pain. So what we're going to do, we're going to talk a little bit about the function of the METs and the toes. We'll talk a bit about the Windlass mechanism, and then we'll look through some general examinations, talk about some possible conditions, and look at the biomechanical factors behind them. I certainly found when I was writing this presentation that the slides were getting broader and broader and wider, and I probably could have talked all day about the topic of metatarsalgia, so I have tried to sort of condense it a little bit, but really the objectives are to make you think more about treating this sort of condition when it comes in. So first of all, let's break the word down, metatarsalgia. So we've got metatarsal and we've got algia, and basically what that means is pain in the metatarsals. So it's a very general term, and it's used to describe various diagnoses that could be anything from capsulitis through to stress fractures and just about anything in between. So it's pain underneath the metatarsal heads, could be with or without a callus formation, and it's probably one of the most common reasons that someone would possibly come and see a podiatrist for. So metatarsalgia is a very, very general term. It's a bit like, you know, saying you've got a headache. It could be anything from, and I've used this analogy before, it could be anything from a brain tumour through to having a hangover rather. So metatarsalgia is not the best diagnosis to use. So do and try, hopefully after the end of this presentation, be a little bit more specific with the diagnosis rather than putting metatarsalgia, because it is very general. Now, the complaint of metatarsalgia with pain under the MET heads, it's often referred to as primary metatarsalgia or structural metatarsalgia, and there is a whole host of etiologies for this. So it can be anything from simple Hallux to something like Freiberg's. Plantar Callus is certainly probably one of the most common causes that we'd see for plantar MET pain. And it's usually limited to the head of the metatarsal phalangeal joint articulation with callus formation that then comes underneath the metatarsal head. So this is usually a sign of abnormal weight bearing or abnormal pressure, and this is usually biomechanical in cause. So basically, the stress of the pressure results in an inflammation on the plantar surface of the head of the metatarsal bone, as well as the metatarsal phalangeal articulation. In older patients as well, the plantar fat pad can atrophy, and this means that there's a reduced cushioning on there as well, and discomfort. So it's really important to try and ascertain a specific diagnosis, but having said that, a lot of offloading prescriptions are often quite similar. So usually the idea is to offload and therefore reduce the pain. But as I say, one of the main things with this is really knowing your anatomy, and that is very crucial. So I'm not going to go into huge depths of anatomy now. I've said this many times before, it's a broad subject and it's something you really need to keep on top of and keep refreshing yourself. And a little picture there. Now this shows a lot more than just the forefoot, but there is more to having pain in the metatarsals than just the metatarsals. Often this can be a result of the way the foot's functioning in the rest of the foot. When you're trying to ascertain what the etiology is, it's well worth working through your layers and thinking what structures are there beneath the skin. So certainly start with your skin and then start working your way down through the layers, down to the bone. So anatomy can be very boring, but it is crucial to making an accurate diagnosis. And I think if you're in a clinic where you see a lot of patients coming with metatarsal pain, or even just a lot of plantar callus in the metatarsal area, rather than getting them back every 6 weeks, think about what's actually causing that and what abnormal forces are functioning as well, and what your anatomy is. Now this slide hasn't come out very clear by the looks of it, but essentially the metatarsal head articulates with the proximal phalanx to create the metatarsal phalangeal joint. So this joint is then supported by the plantar plate, and then the flexor digitorum longus and the flexor digitorum brevis tendons. They then travel through a slight groove, which is on the bottom or underneath the metatarsal head, and they then attach into the base of the distal and middle phalanges. You've then got the extensor hood, and that basically envelopes the dorsal part of the toe. Now, critically, and this is something that often goes wrong, the metatarsal joint is supported by the plantar plate, and this is a rectangular type ligament that attaches to the inferior metatarsal neck, to the plantar aspect at the base of the proximal phalanx. This structure is basically responsible for supporting the static structure of the foot, and then also on the collateral ligaments that support the medial and lateral sides of a joint. So anyway, as I say, you can't see it wonderfully clearly on there, but it's definitely worth sort of almost knowing this inside out if you see this presentation quite a lot in patients. So let's have a look at the function of the metatarsals and what's the purpose of the metatarsals. Well, basically all of your body's weight, all of your patient's body's weight will pass through the metatarsal, and essentially the first metatarsal takes the brunt of it. The only thing with this is if the first metatarsal can't bear its share of the weight, then problems occur on the lesser metatarsals, and as a consequence, they suffer. So conditions like hallux valgus or short first metatarsal, metaductus, or something like proximal placement of the sesamoids, all of these can reduce in a reduced weight bearing for the first ray, and this can then end up increasing or transferring pressure onto the lesser metatarsals. Also, things like excessive pronation with the forefoot supinatus, that can do this as well. So you end up indirectly creating more force underneath the lesser met heads. So it's all quite finely and intricately balanced to do the function that it should. So our little toes, what do? Well, they increase weight-bearing surface area. They help to stabilise the foot. And very, very basically, they sort of aid balance, proprioception, and they help with general movement. Now, during gait, the toes are in contact with the ground for around about 3/4 of stance phase, and they exert pressures similar to those that you'd see in the metatarsals. There's quite a few papers that refer to that. At this point as well, I'm going to apologise for the fact that I haven't referenced this this presentation. I'm very happy if anyone contacts me to send you some references. But it takes rather a long time to do that, and as I said, this was quite a broad subject, but as I say, there's lots of papers that look at certainly plantar pressures associated with metatarsalgia. Anyway, I digress. So whether we call them toes or whether we want to be more specific and call them digital stabilisers, there's a lot going on pretty much all of the time, and if you think about the anatomy and you think about how small some of these little structures are into relation to something like the hip joint, it's no wonder that the problems can occur. So I've listed a few structures here which are playing a role constantly when the foot's static. So you've got the capsule around the joint, the collateral ligaments, plantar plate, plantar fascia, and then dynamically you've got the intrinsic muscles working, the interossi and the lumbricals. Often it's the intrinsic muscles which are thought to weaken initially, and then they end up leading to other problems, sort of things like the joint capsule. There's also a line of thought which suggests that our reliance on footwear over the centuries has in fact been one of the reasons that we're more prone to forefoot problems, because we've weakened those intrinsic muscles. So, and there's a few papers on that as well. Now, I can't talk about the forefoot and potential problems without talking a little bit about the good old Windlass mechanism. So this is just a little bit of a recap. Basically, it's a bit like a winch mechanism. It's been around since Hicks first described it in the 1950s. If the hallux is dorsiflexed, it essentially pulls on the plantar aponeurosis, draws the first metatarsal and the calcaneus closer together, and as a result, that raises the arch. That then makes the midfoot more rigid, and it gives you what we describe as that rigid lever to then push off with. So it looks and sounds simple enough, but it does rely heavily on the first met being aligned very well in the transverse plane. And it needs to be perfectly aligned or well aligned for that windlass and the plantar fascia to function efficiently or effectively. So, of course, if this is compromised, if you've got things like bunions or functional hallux limitus, then you can get compensations that can occur elsewhere. So it's always very, well worth checking first ray function in weight bearing. If you're tackling problems with the forefoot, because that often has a part to play. It might not be the sole cause, but it often contributes. So possible conditions we can see when we're talking about metatarsalgia. Let's have a look. We've got corns and callus up there, probably the most common things we'll see. Plantar plate tear or plantar plate rupture, stress fractures, bursitis, capsulitis, tendinosis, so with some of the smaller muscle attachments there. Osteoarthritis of the actual joint itself, Freiberg's, not particularly common, but I guess if you've got a teenage girl coming in and she's presenting with something which is looking more like a stress fracture, then Freiberg's would be something you want to rule out. Rheumatoid arthritis, capsule sprain, plica, which is a fold of the synovial membrane. And then, of course, you've got trauma as well, but then your patient will give a history of that. So most of the time, like I said, it can be something just as simple as plantar callus, but you've always got to question where that actual callus has come from and what's caused it in the first place. Oh, didn't realise I'd done that. Got a little picture sliding in there. So when it comes to making an examination, the first giveaway really would be your presence of a plantar callus, and you can see that straight away. But a very handy, quick and easy test to do is the dorsal draw test, or a mini Lachman's test as it's called. So, and you can just see that from the picture I put up here. So what that does is it pretty much assesses the integrity of the plantar plate of the toe at the metatarsal phalangeal joint. So you need to sort of take both sides of it and try to manipulate it. And what you should see is like a mild translation when the plate is intact and everything's normal. If it's torn or ruptured, it's quite easy to get a lot more movement, and you can almost sort of dislocate the joint. I think the best benchmark for this is to compare it to the other foot or another joint which isn't affected, because everybody is different. So some people will be a lot more mobile and you get a lot more gliding, and others will be a lot stiffer. So you can't sort of compare it between people, but I would certainly compare what you think might be a problematic joint with other joints on that same person's foot, or certainly the other foot. Other things we can look for is localized swelling in the soft tissues around the bones, things like sensory testing for local neuropathy, squeezing the metatarsal heads together to see if there's a Mulder's click or a Mulder's sign, and that will give us an indication of whether there's an interdigital mass such as a neuroma or bursa. I think often when we find an interdigital mass, we assume it's a Mortons Neuroma, but quite commonly it is a bursa as well. When it is a neuroma, there's often an accompanied kind of nerve-type pain or paresthesia that the patient might feel with that as well. So you've probably noticed I've mentioned plantar callus quite a few times, and I think that's probably because I've seen in lots of clinics in the past patients coming in every 6 weeks to have their plantar callus reduced. Or people will be trying to sort of offload it, but nobody's really looking at the biomechanics behind it. So it's very easy to neglect this and think, oh, it's just older patients. When they get older, they get plantar callus. That's what happens. But the callus is there for a reason, and quite often it's under the second met. And when it is under the second met, it can be, or it can usually be due to a short first metatarsal, which then increases stress under the second metatarsal, and then subsequently you get a large diffuse piece of callus that forms. Another common one you see is something like hallux valgus, which is a very common deformity, especially in your older female patients, and that very often comes with associated second metatarsal callus and pain. And again, that's because the stress absorbing function of the first met just reduces. Could also be because there's not enough range of motion in the first, so you get that abductory twist, which is adopted as your patient walks, because they can't push off through the first. So they end up doing a slight twist, which then causes shearing stress underneath your second and third met. So in that case, it's your first metatarsal function that you need to be addressing there. When you get callus, which occurs under the fifth met, it's usually because it's just a more prevalent met head, which you might see with the cavoid foot. And when the callus is under the first met, it could be due to an enlarged, something like enlarged tibial sesamoid, or excessive plantar flexion of the first ray. So when you see a foot like this, or slightly worse or slightly better, always think about exactly where that callus is occurring. So rather than just thinking, oh, they've got plantar callus, think about, is it occurring under the second, is it under the first, is it under the fifth? Because different locations will give different indications as to what's causing it. Now, slightly more problematic diagnosis than plantar callus is a stress fracture, but they're also not uncommon, especially if you're treating people like sports patients or army personnel. So this is usually caused by repeated pressure that overloads the body's ability rather to repair itself. This then um, fatigues the bone. So if you think about Wolff's law of functional adaptation of bone, basically what's happening here is that your stress outruns the repair process, and then you end up getting a stress fracture because the repetitive microtrauma is happening at a greater rate than the body can repair. So generally speaking, these patients tend to present with swelling and pain in the forefoot, which worsens with walking. They can also report that it's worse if they're walking without shoes or if they're walking on uneven surfaces. So an X-ray is obviously the best way to confirm this. But usually, if you can identify a specific location of pain and swelling, and that area of pain tends to be more on the shaft or the neck of the metatarsal, that can be suggestive of a stress fracture. Now, Mortons Neuroma is well documented. I think this is probably one of the first forefoot conditions I learnt when I was at university, and goodness only knows how many people I diagnosed with Mortons Neuroma early on that didn't have it. So it's very well documented, very well known diagnosis. A lot of your patients will have heard of this as well, especially if they've Googled their metatarsal pain. They'll probably come in and tell you they've got Mortons Neuroma. It tends to be a mechanically induced degenerative neuropathy, which most commonly affects the third common digital nerve. Now, this nerve tends to be more vulnerable than the other ones because of the excessive motion which can occur between the third and fourth metatarsals. So again, if your first ray isn't functioning properly and that windlass mechanism isn't kicking in and it's not locking up the bones of the foot and making it as rigid as it should do, then you could end up getting more movement between these metatarsals, and then as a consequence and a subsequence, you end up creating or ending up with a problem like a neuroma. Also in this area, you've got the compression from the overlying transverse intermetatarsal ligament, and that can have a bearing and cause pressure on there as well. Now, high heel shoes don't help. That's probably why this condition tends to be more prevalent in women. But what basically happens is that over time, these nerve fibers degenerate, and then the repair process causes a fibrosis. This then enlarges the nerve, and then it makes it even more prone to compression, and so it kind of goes on from there. Do always think with this one, think about your differential diagnosis, and bursitis are quite common in here as well. Remember having a conversation with a paediatric surgeon once who commented on the number of referrals he got to excise Morton's Neuroma, and most of the time they were actually bursitis. It wasn't any effect on the nerve at all. So I haven't got any literature or evidence for that, but as I said, it's not always a Morton's Neuroma. So. Now, what happens with lesser metatarsal instability? And I think this is a common one which is often overlooked. Well, the intrinsic interossei and the lumbrical muscles, they flex the metatarsal phalangeal joint and extend the proximal and dorsal IPJs. And basically what happens is that they're overcome by the stronger extrinsic muscles. So extrinsic muscles are your extensor digitorum longus, extensor hallucis longus, and flexor digitorum longus. And what this does is it causes a hyperextension of the metatarsal phalangeal joint, and then a flexion of the proximal and distal IPJs as well. So it ends up causing something pretty much like a hammer toe, and that's something that we see very, very often. But you can see different presentations in different planes of movement, and I'll come back to that in a minute. So what causes metatarsal instability? What causes these wandering toes and hammer toes? Essentially, it's actually this repetitive trauma causes damage to the joint capsule, or the collateral ligaments, or the articular cartilage, or the subchondral bone, or all of them. So, and it's generally repetitive trauma that does that. So it's something like maybe too much walking or the wrong footwear. Do always bear in mind there could be an underlying medical condition, so diabetes, rheumatoid arthritis, so it is always worth taking a good medical history. Certainly synovitis from rheumatoid arthritis in particular can affect the metatarsal phalangeal joint ligaments and capsular structures, and that can result in a dislocation. So, as I say, it's very important to ascertain their medical history as well. Poor footwear, of course, causes a multitude of problems and can cause to this as well. Now, the previous, or not the previous slide, but the slide before that, I mentioned the importance of different planes. And I always think it's important to stress this, and I've mentioned it several times in relation to the subtalar joint, and that sometimes it's very easy to get fixed in one plane of movement. And typically when you look at the subtalar joint and we think about excessive pronation, we always think of it in the frontal plane, and we post the frontal plane to stop the pronation. But I mean, the subtalar joint functions in the frontal, sagittal, and transverse plane. And when we look at the forefoot as well, and we need to think about what plane it's functioning in. So hammer-tone deformity causes the proximal phalanx to push down on the dorsal aspect of the metatarsal head. This then causes the MTPJ joint to stretch and the joint to degenerate. So all of that occurs within the sagittal plane. Now, if you've got disruption to the collateral ligaments and the plantar plate, this is then occurring in the transverse plane, and that's what can cause your toe to cross over the other one or deviate laterally or medially. Doesn't always just happen in one plane, can often happen simultaneously, so you get movements in both the sagittal and the transverse plane. So you could end up getting toes crossing over with hammer toes, so sort of things you see quite commonly with rheumatoid arthritis. But certainly understanding which plane the compensation is incurring in is a step closer to choosing the right orthotic treatment. So these are just a few things you can see. Should have put some more pictures in here, really. Also, it's worth bearing in mind that different clinicians and different practices will call them different things. But crossover toes, hammer toes, plantar plate disorder, pre-dislocation syndrome, that's a nice sounding one. Sounds better than a hammer toe, doesn't it? Floating toes, splayed toes, spread foot. So all the sort of things you see where basically you're not seeing a nice normal straight forefoot. But as I said, if you look it up in the literature, they're called a whole host of different things. But usually this is the primary cause of this is instability in those lesser metatarsal phalangeal joints. So there's just a few treatment suggestions there as well. So if you're addressing the transverse plane, you can work with things like digital spacers or metatarsal binding. Bunion splints are certainly very successful for some patients. And if you're looking at things in the sagittal plane, like your hammer toes, then manual stretching can help, along with digital taping and splinting. And maybe a combination of all of them if you dare try it, if you've got things occurring in both planes. Now, I'm not going to go too much further with this presentation without talking about a bit more biomechanics. So here we have it. Now, it's really important to know and understand what the underlying biomechanics are if you want to have good treatment outcomes. And you can try lots of different things, but if you understand what you're trying to treat biomechanically, then you should get there a lot quicker. Now, granted, you could get your patients back every 6 weeks for callus debridement, but I think it's really important to think about what's causing that callus in the first place, and also what's happening underneath that callus. What's happening is the joint degenerating, is the problems with the capsule. What else is happening underneath that area of high pressure that we can't see? Excuse me, there goes my first cough. So here are some of the mechanics that we might see behind some of the problems, and these are what we need to address. So I've got on there short first met, hallux valgus, functional hallux limitus, heel lift, ankle or forefoot equinus, and these are the things, as I say, that we need to address. So most of the time it's very easy to pick those things up from a good examination. It's very easy to see if they've got a short first met or whether they've got an HAV. But we need to look at addressing the predisposing factors here. I need to also add that we don't want to forget about systemic causes. So, as I say, always think about rheumatoid disease, ligament laxity, neuromuscular disease. And I haven't really touched on differential diagnoses in this presentation, but you always need to be aware and consider those things as well. So basically, if we want to address a short first met, what we're trying to do is artificially elongate the first metatarsal to reduce the forces on the head of the second metatarsal. And this modification works really well for that. I'm not sure if you can see from the picture there or whether you can see what I mean, but we're just putting a shaft underneath that first metatarsal. Now you can experiment with different materials, and sometimes it really is just as simple as sticking a bit of semi-compressed felt onto a prefab, so it follows the line of the met shaft, and that can work really well. I always remember an incident where I think it was probably the second biomechanics clinic which I ever did after I qualified. And I had a patient referred in with first met pain, and she'd come from the London Foot Hospital, and her notes were like War and Peace. And I just remember thinking, you know, I'm never going to be able to replicate or do a good enough prescription for this woman after I read through it all. And then when she came in and I looked at what she had and what had worked, it was simply a Freeland with a beveled piece of poron to emulate that first met. And so after all the testing and all the imaging and all everything that the treatment and management she'd had, this was the best thing, and this kept her completely pain-free. So, I mean, that was very easy to do in the lab. But if I hadn't have seen that, I probably wouldn't have believed that something this simple could work that well for those sort of patients. Now, Hallux valgus, HAV, very, very common. And what we're trying to do here, our objectives are to reduce the pain and improve function if we can, although it depends at what stage in the HAV that is. So rocker bottoms, they're great for transferring weight through the sagittal plane, and the easiest way to do this is selecting the right footwear so that the foot gently rocks through. This works really well for patients with HAV and also reduced range of motion in the first, whether they're weight bearing or non-weight bearing. So even an arthritic Hallux Limitus, this can work well for as well. Another tip, and I've pictured it here, I got this from Richard Boucher at the Biomechanics Summer School last year, was binding the forefoot to reduce the first to second intermetatarsal angle for patients with HAV. Now, I wasn't convinced until I tried it, but I found this works really well, especially for younger patients that have got more flexibility, so you can manipulate it back again. So like your stage 2 HAVs, I found this has worked really well for. So I've also borrowed Richard's picture here, so credit where it's due. Thank you very much for that. Functional Hallux Limitus, this is something I could talk about for a lot longer and do a lot more slides on. And many and varied are the things certainly that I've tried to get more motion in a joint where you've got the flexibility when they're non-weight bearing, but as soon as you get them weight bearing and try to move that hallux or try to manipulate that first MTPJ, you're just getting no movement there at all. So what we're trying to do with this is increase first MTPJ range of motion. There is some evidence that MET domes can work, and that's because it aids first wave function by reducing the pressure underneath the first. Now, I've also tried things like adding lateral forefoot posts, but what I would say with this is not the same thing doesn't always work all of the time. So I could have 10 different patients come in and they've also got functional Hallux Limitus, but I might try 5 different things on there and different things would work for each of them. So it does take a little bit of playing around with sometimes. Typically, I think probably the most common modifications I would use, or the modifications that are used by colleagues and generally, are first met cutouts and kinetic wedges. So you just need to remember that there's no osteoarthritic lipping on the dorsal aspect of the joint. Otherwise, you're going to get that first met going, and then you're going to aggravate the joint space even more. So you need to make sure the flexibility is there when they're not non-weight bearing, if you want to try and achieve that when they're weight bearing. Another thing you can try with this is a distal hallux wedge or a Cluffy wedge. And with this, it's just a small post that you stick underneath the distal phalanx, and so effectively you're posting it in the sagittal plane, and this creates almost a toe rocker to be able to push off through. So again, if they've got the flexibility, or young patients, this works very, very well. But if you've got older patients with some osteoarthritis in that joint, then that extra movement that you're creating there and that preloading of the hallux can cause more pain. So select your patients wisely with that one. Right, I'm going to have to take a mouthful of water now. My throat is very slowly drying out. So sometimes an early heel lifting gait means your patient will spend more time on their metatarsal heads. So simply by adding a small heel raise, what you do is end up bringing the ground up to meet the foot, and that effectively shifts the weight back off the metatarsals again. You obviously have to be careful with this that you don't create an ankle Equinus, But if you've got an older patient who's got quite a rigid foot and maybe a bony equinus, then a heel raise can work quite well with that, and certainly cavoid feet this can work quite well with. But basically what you're doing is maintaining heel contact with the ground for longer by doing that artificially with a heel raise. Now this is an interesting one, tight calves, ankle equinus, and I always think the number of problems you can end up getting because of tight calves is quite remarkable. So in this instance, let's just look at the biomechanics here of how that affects forefoot loading. And in very, very basic terms, if you haven't got the flexibility in the ankle rocker, then that bend or that movement in the sagittal plane to get the body over the foot, that's got to occur somewhere. So it essentially moves on to the next possible point, which tends to be the forefoot, and that results in increased forces underneath the forefoot. So just something as simple as having tight calf muscles just ends up meaning they load their forefoot for longer, and they can end up getting pain underneath the forefoot because of that. So the lunge test is quite a good way to check ankle flexibility. You're not checking any muscle group in particular there. Basically, you're just seeing how much flexibility your patient's got underneath their own body weight. And it's measured, as I've shown in the picture there, just with your patient standing up against the wall and just seeing how far they can move their heel back without it coming off the floor. So just get them to do it gently. They don't need to sort of break anything or cheat or anything. You're just looking at how much flexibility they can get there. And then obviously passive range of motion testing with your patient laying prone or supine is a good way to test flexibility as well, and also see if there's any bony blockage with that one. So treatment for this, our aim is to increase that sagittal plane efficiency. So think about Dannenberg's sagittal plane theory here. So the three body rockers, the heel rocker, the ankle rocker, and the forefoot rocker. And there are several ways with an orthotic that we can achieve this and make this better. So rocker footwear is always a good one. Doesn't have to be orthopedic or anything expensive. It can just be a good shoe with a sole, a bit like the ones you might see on our Stride footwear, where you've got that gentle rocker underneath that just allows that sagittal ambulation and lets them move through the sagittal plane. Stretching exercises will always help. And I must say I've had quite a few patients who usually come in with something else, but metatarsal pain has been sort of a secondary thing they complained of, and quite often just with stretching exercises alone and good footwear, and that metatarsal pain has resolved. So that is always worth bearing in mind. If the equinus is more of a bony block and you're not going to achieve that flexibility with stretching exercises, then you can add a heel raise, as we mentioned before. And also don't forget, if you have got an ankle equinus and excessive pronation, it could be the excessive pronation which is occurring as a result of the ankle equinus. And what happens there is that because the body can't go over the ankle, it ends up going around it. So the foot pronates basically to take the body through a different route. So if you address the pronation, you block the pronation, you're blocking its adapted path. And you can end up causing even more problems elsewhere. So if you've got pronation and you've got an ankle equinus, think about it's a bit of a chicken and egg thing. Think about if one's affecting the others, and if you take one away or if you treat one, what's it going to do to the other? So as with any condition, always keep an open mind. The causes of metatarsalgia are many and varied. And there are many things that can lead to increased forefoot pressure. But the thing with that is they might not always come from the foot. So things like knee arthritis or hamstring contractures, that can have an effect on knee kinematics. It can limit knee extension, and that would then lift, or that would then shift your centre of pressure or the weight forward onto the forefoot. Things like obesity, pregnancy, older age, and different sort of stances, people's different postures, all of those things can have a bearing on forefoot pressure. So don't always get too tied in with looking at the forefoot and forgetting what the rest of the body is doing. Limb length difference as well, that's another one that can have an effect. So a few orthotic modifications that we can consider here, and they are many and varied, and as I said, I could talk all day about different modifications that we could try, so I'm just going to touch on a few here. So total contact or total contact orthotic, this is, I mean, you could do it in the at-risk foot sense, if you're making a custom-made fully functional orthosis, you can achieve this easily by adding something like a no medial addition, and that just basically means that it brings the arch up closer to meet with the natural arch of the foot. So this is particularly useful if you're treating something like a pes cavus foot, because it offloads the metatarsal head because you're spreading the load over a greater area. So yeah, if you're getting forefoot pain because they've got a cavoid high arch foot type, then making your orthosis total contact really helps spread that well. Rocker bars, and they're great and effective for reducing central forefoot pressure. Obviously, you need the footwear accommodation with this, but basically a device which has got a rocker bar on is intended to offload the MET and then transfer the forces more quickly through the forefoot during the gait. So you're not necessarily making the forces any less, but you're moving them through quicker, so it's causing less of a problem. So this is quite a good solution for patients with things like rheumatoid arthritis, because one of the risks of that is you can end up having breakdown and ulcers occurring because of the length of time they're spending on the MET heads. So a rocker bar will just move them off this much quicker and reduce the likelihood of getting ulcers. What else have I put on there? A MET bar. Now I tend to find with these, different clinicians call them different things, and we've got different things in our catalogue. And as I say, patients ring up, and not patients, rather clinicians ring up, and they've got different terminology for it. So when I say MET bars, what I'm talking about here is a pad of about 10 millimil thickness, which you would add to the distal edge of your orthotic and just proximal to the metatarsal head. So it doesn't go under the metatarsal head, it sits just proximal to it. And there's been quite a few studies which have shown that this really helps reduce peak plantar pressures in this area. So it's one that can actually work really well if you're doing that minimal arch fill with a cavoid foot type because of the offloading. One thing I would say with that actually is if you are thinking about treating a cavoid foot, is to think about the choice of orthotic material. It's very tempting to go for an EVA or something soft and cushioning because of the shock attenuation. But often you want a more rigid or semi-rigid material that will fully support the forces coming through the foot. So that is worth bearing in mind. A Neuroma plug. Again, this is something I've seen called all sorts of different things, but it's basically a thin piece of material, usually porn or EVA, which you'd need to mark on your cast, or if you're doing it on a simple insole, placed between the metatarsals. And what that does is it splays metatarsals when the patient's weight bearing. So it can work very well for things like neuromas or interdigital bursae, those sort of things. But the key there really is getting it in the right place. Now, MET domes, in my experience, people either like them or they don't. They seem a bit like Marmite. And when I've looked for all the evidence, there's actually no hard and fast data that any particular shape of dome or any size of dome is any better than any other. So no hard and fast rule with this one. What I would say, or what I found, is that if patients find them comfortable straight away, they tend to work better than when they put them in and say they feel uncomfortable, and they'll get used to them. And I think this really ties in with Ben O'Nigg's biomechanics theory of preferred pathway, where if something's comfortable, well, Ben O'Nig puts it in far more detailed terms than I'm going to. But essentially, if something feels comfortable when a patient first wears them, it tends to be more effective than if they don't. Ben is actually talking at our summer school this year, so and he will be touching on that. So yeah, do come along to that or tune into it if you can. Right, and then there's cushioning. So cushioning the area, a lot of us tend to do this. It's a very obvious and simple way to treat something which is painful, and it also gives instant relief to your patient. So it certainly works well initially, but you're not always necessarily tackling the biomechanics. If it's a simple case of fat pad atrophy in older patients, and it can be very effective. And I suppose the only thing biomechanically is it does dampen the velocity, which is why it gives almost an instantaneous relief to your patients. But do remember with this that cushioning materials do tend to bottom out very quickly. So something that's comfortable straight away as they walk out of the clinic may not last much longer, depending on how much they're walking or sort of what weight they're putting down through it. So it needs to be replaced fairly often. So a little bit I'll say about prevention. I think it's always worth mentioning prevention, although sometimes it's very difficult to convince your patient about this, especially if they're not experiencing any pain. Certainly, I suppose, prescribing custom-made orthoses in the absence of a specific diagnosis will be hard and might be questioned. But if it's something just as simple as an ankle equinus, then that might well be worth addressing with stretching exercises if that's what you think's appropriate. I guess where prevention really does come into its own is when you're dealing with the at-risk foot. And in this instance, there's a very good case for preventing the problems before they happen, especially things like plantar pressure ulcers. And there's also a lot of good evidence to help support this. So yeah, prevention's always better than cure. The trouble is, I guess, with if it's just mild or simple problems as such, patients aren't going to come and see you until they've got the pain or until they've got the problem. Very few of them are going to come and see you with perfectly pain-free feet and ask you to do a biomechanical assessment and treat them to prevent anything which may happen. So yeah, prevention is important, but not always easy to implement. Now, coming to a conclusion, I think this little illustration here kind of sums up how I felt by the time I got to this stage. As I said, I could have ended up writing and talking about goodness only knows how many different conditions, because it is a very, very broad subject. If you look metatarsalgia up on the internet, you can see these very nice little concise blogs and documents written about metatarsalgia, but it could be a whole host of a number of things. And there could be a whole host of number of different treatments and orthotic modifications which you could do to treat it depending on what the problem is. So I guess my advice here is have you got a better diagnosis than metatarsalgia? And certainly in clinics I've worked in the past and assessment forms that I've seen, it's very common to see this as a diagnosis. And certainly again in the literature you look at, you'll see this as a diagnosis, but it is a very, very vague and broad term to use. So I think really establishing an etiology is very important. Rule out any systemic issues and try and pinpoint the mechanical origins of that pain. And this is really crucial to getting the right prescription with your orthoses. I think as well, if you're in doubt, then always adopt a tissue stress approach and just try and work through it methodically and think about what is causing the affected structure to work outside of its optimal zone of stress. So in a lot of cases, the structure, whatever it is, whether it be the capsule or the plantar plate, the ligament, whatever it is, usually it's subject to some kind of repetitive micro trauma, and that's what we need to try and work out, and that's what we need to try and combat. So, on that note, I hope I haven't ended up confusing anyone anymore or causing more questions than I've answered. But yeah, it is a very broad topic. And if you do see a lot of patients that come in with metatarsal pain and certainly plantar callus in different areas, it's certainly worth looking into more and certainly knowing your anatomy. So, any questions? If you type the questions in, I'm going to try and get that little box back up and have a look in a minute. Also, you'll receive an email shortly after this if you want to re-watch the webinar or if you want to pause bits of it or pause certain slides. You can also get a 20% discount off bio products for a certain period of time, and the details of that will be on the webinar, on your email rather. So definitely worth looking at that. 20% is a good discount. Right. Of course, this is the point at which I realise that my microphone has stopped working halfway through and everyone's gone. Okay, someone's put thanks, so I'm guessing that's worked. Thank you, Jose. You always give me nice feedback. I think the trouble with doing webinars is I realise I can sit in my own little world looking out the window, chattering away and skipping through the slides. I've got absolutely no way of knowing whether the microphone stopped or whether the video's cut out or whether you're all sat there in darkness and no one can hear anything. So Amanda's put that's really helpful. I hope so. Oh no. And then someone's just put, oh, that very thing that I could listen, but I couldn't see the pictures. So yes, you will get an email that will come certainly at some point today, and you can re-watch the webinar and listen to it as well. So, and sometimes I think that's even easier because you can do it in your own time and you can pause bits of it as well. So you can have a tea break in the middle or something. Okay, so somebody's put there, how does one diagnose a neuroma? Certainly manipulating, feeling for a Mulder's click, and feeling for some kind of nerve type symptoms, or asking your patient for what they're feeling can help narrow it down. But yeah, ultrasound would probably be your best bet for that, because then you're looking for an actual mass underneath that. If you haven't got an ultrasound machine, which many of us haven't, then I would refer on if you suspect that. I always think that's better than referring them straight to a surgeon for a Mortons Neuroma and then finding it's not a neuroma. So, but you'd want to have an idea of what it was from your manipulation and examination before you sent them from an ultrasound. I think as well, don't be scared to try different things on prefab orthoses and try different things in your clinic. I mean, the amount of things I've tried just with semi-compressed felt, all sorts of weird and wonderful spacers and domes and bars and things to try and achieve different things. And you can do that and try that and get patients to walk around your clinic and almost have a little bit of trial and error with it. Things like adhesive back pawn as well. If you bevel the edges with a pair of scissors, all sorts of things like that can help. Or even a more sort of medium to harder density EVA if you're wanting to create spacers. You can almost have a little bit of a Blue Peter session going on, trying to get the orthotic right for the patient. So I think as long as you know what you're trying to address, then you've got the justification for trying that. Yeah, and someone's put there, it can sometimes just be a neuritis. Yeah, absolutely right. Okay. Yes, you definitely need to revise planes. Plantar bursitis, how common are they? I'm going to stick my neck out here and say not very common, or I haven't seen that many. Then I'm not saying that I haven't missed them. I shall probably go and look that up actually. I've got a few colleagues that have invested in ultrasound machines. I mean, they are very expensive, but I mean, they're absolutely brilliant for diagnosing. Yeah, isobottle exercises for plantar fasciitis, they work really well. I mean, ice works really well on anything where there's an inflammation. So if you've got an inflammation around any of the structures in the forefoot as well, that could work. Would I get them stretching more than twice a day for ankle equinus? First thing there I would say is make sure it is a soft tissue equinus, rather than a bony block. The trouble with this is ideally you want them stretching at least 3 times a day, and you want them holding the stretch for at least 30 seconds. The trouble is patients, no matter how clued up they are, don't always have the time to do this. So, which is why, although there's different stretches that you can do which are more effective if you want to stretch just the soleus or just the gastrocnemius, sometimes I think the most effective way of doing this is just getting them to stand on don't we have telephone books anymore, do you? But on a book or a piece of wood while they're doing something which they would do every day anyway. So if they brush their teeth twice a day for 2 minutes, get them stretching while they're doing that. If they do their hair or have a shave once a day, anything which you can adopt or get the stretching into their daily routine is a lot more effective than giving them a whole host of stretching exercises, which they should be doing, 3 and 5 times a day. So ideally, yes, you would want them stretching more than twice a day, but you've also got to be realistic with patients as well on what they're going to do. And sometimes if you go a bit overkill, they end up not doing it at all, which doesn't help either. So I've treated, athletes and sports people that know full well the importance of stretching, and even they're just as bad as doing stretching exercises. For footballers, if they're in the changing rooms and they've got their physio there at hand who's on at them all the time, then they're really good at doing it, but leave them to their own devices, they're pretty bad at doing them. So always think about your patient expectations and what they're going to do as well. Oh, I see you watched the webinar last year about the small bottle of ice. Just realised I think everybody on here can see everybody else's questions, can't they? Right, okay, on that note, I think I'm going to let you all go and get some lunch. So thank you very much for listening. Remember to have a look at your email, and don't forget you get that 20% discount on there as well. So, okay, take care everyone, and if anyone's got any suggestions for conditions or for future webinars, then just drop us a note and let us know.